everybody. So today we will be doing our last session on urothelial carcinomas, and today we will be talking about upper tract urothelial carcinomas, which is much rarer as compared to bladder cancer. But once you diagnose or suspect it, it has to be taken much more aggressively. So Dr. Hamad would be talking about it. So
Okay, thank you very much, Vijat. So we're going to talk about protract urothelial cancer. And as you know that today is the last of the theoretical aspects of bladder cancer. So we have discussed non-muscle invasive, muscle invasive, 2 sessions, and now upper tract urothelial cancer. From next Saturday onwards, we will be doing the technical and the surgical aspects of bladder cancer, and we'll take up all these surgical procedures and talk about the tips and tricks and also the surgical aspect with the video and technique of procedure. So all of you who have not yet registered can follow this link, and Sharif will paste this link in the chat box as well and get registered so that you can be given a certificate for attendance. So I have no conflict of interest related to this presentation. Okay, so we all know that urothelial cancers are heavily linked with use of tobacco. So if you are a current smoker versus you're an ex-smoker, the chances increases significantly. So from 2.5% for ex-smokers to 7% to 7 times. If a non-smoker is 1 or 0, then 2.5 times more chances to develop in ex-smokers and 7 times more chances of. Two other things which are pertinent to upper tract urothelial cancer and not that much to the bladder cancer is the use of a Chinese herb called aristocolic acid, or these herbs are called wild ginger or bitterworth, and in Urdu it is called hamal bale or nag plant or something. So it looks like a snake. And this is something which has a high content of aristocolic acid. Aristocolic acid combines, is a heavily excreted in the urine. Is a nephrotoxic as well as carcinogenic. It binds with the DNA, resulting in mutation. And these persist for years. They form DNA ducts, which persist for a long time in the urinary tract, and they can cause activation or deactivation of P53, the tumor suppressor gene, and HRAS, resulting in development of. The other thing is alcohol. Alcohol is not directly linked with bladder cancer, but it has a very strong correlation with upper tract urothelial cancer. So there's significant increase in chances of never drinkers to ever drinkers. And it is also linked to the amount of alcohol consumed. So greater than 15 grams of alcohol per day increases your chances of developing upper tract urothelial cancers. And we have seen young people with alcohol addictions developing very aggressive bilateral upper tract urothelial cancers. Obviously, patients with the history of bladder cancer are also at risk of developing. Now, if you look at the EAU guidelines of upper tract urothelial cancer, it's very clear that the low risk cancers, which is a single disease with a size of less than 2 centimeters, with negative cytology on urine sampling, the biopsy shows that it's a low-grade tumor, and the CT scan indicates that there is no invasive disease, T3, T4. So if you have all these features, this is called a low-risk cancers. Whereas if you just reverse it with the addition of presence of hydronephrosis, history of radical cystectomy in the past, variant histology of bladder tumor, as well as in the upper tract urothelial cancers, then this become a high risk disease. And If you look at the treatment options, vast majority of low risk urothelial cancers are treated conservatively, which means by resection and by intracavitary treatment, whereas high risk cancers are by and large treated by radical nephroureterectomy, which is the mainstay of treatment, like bladder cancer. So it's pretty simple. You don't really need to attend the rest of the 50 minutes of this webinar and go home. Just classify your tumors into low risk and high risk, and that's it, and do nephro. But I'm going to illustrate with some of the cases that we have dealt with and show you that life is not as simple as is indicated by this algorithm. Lynch syndrome, some of you may have heard about Lynch syndrome. It's hereditary non-polyposis colorectal cancer, and it is associated with a lot of tumors in the body, which from the urological perspective, predominantly include the upper tract urothelial cancer, but also prostate cancer. But upper tract urothelial cancer is more. So people who develop these cancers before 50 years of age, they should be screened for Lynch syndrome so that their family members can be screened and appropriately counseled. Now let's start with the upper tract, the low risk urothelial cancer. Uh, the the advent of flexible ureteroscopy has really changed the way we treat with upper tract urothelial cancer. I remember that 20 years back, most upper tract urothelial cancer were treated invariably by radical nephroureterectomy. And our distinction of low versus high was not that clear because we are unable to biopsy these tumors because ureteroscopy, particularly flexible ureteroscopy, was not that easily available. But now things have changed. So flexible ureteroscopy has really changed the way we deal with the upper tract urothelial cancer. The low-risk cancer or low-grade cancers have a very low potential for metastases, and that's the same thing which non-muscle invasive bladder cancer. So it's important that we make the diagnosis of low risk or low grade cancers versus the high risk cancers very clearly during our workup. So the biopsy technique should be standardized, the specimen should be appropriately assessed. And if you have all this and still you have a low grade cancer, then it's quite obvious that you're dealing with a low risk disease. And by and large, these diseases can be managed conservatively. Urine cytology should be negative. That's an important step. So let's do a little mental exercise. This is question, multiple choice question for low grade upper tract urothelial cancer. Following tumor resection, which modality would you consider for intracavitary chemotherapy? An intravesical chemotherapy with a double J stent so that it refluxes into the upper tract. Intravesical chemotherapy suffice, there is no need for double J stent. Intracavitary chemotherapy via percutaneous approach, and intracavitary chemotherapy with an open-end catheter. So you put an open-end catheter, you put the medicine, and then you remove the catheter. And so you can start answering now, and we are seeing that we have choices coming predominantly D and C. So okay, so I'm not going to tell you what is the correct answer if there is one correct answer, but let's go through some of the cases that I'm going to discuss with you, and it will become quite obvious what's the correct answer. So just keep it in the back of your mind, what you have answered. Most of you have said D except for 1C. So, okay, fine. Let's move on. Another question. So during the course of management of low-grade upper tract urothelial cancer, when will you do ureteroscopy for the contralateral side? So you're doing surveillance, and whenever you are doing surveillance ureteroscopy for the affected side, you would do it on the other side as well. Only when there is a progression of disease, only on clinical or radiological evidence of disease on the contralateral side, or once a year. Okay, let's look at some of the choices. So B and C. Okay. So far B and C are coming out as the answers. Perfect. Okay, again, we'll just not address this issue right now, and we will talk about it a little later. Okay, so this is case number one. And through these cases, what I'm trying to do is to highlight the difficulties in management of this condition. It is often termed as an enigmatic disease, really difficult disease to treat. So we have a 68-year-old male with microscopic hematuria, which was persistent for the past 3 months. He is diabetic with mild obesity, good functional class, serum creatinine of 1.2, hemoglobin good. He has a history of 20-pack year of tobacco consumption, cigarette use, and this is his CT scan. And this is the contrast enhanced of the same patient. Okay, the arrows are there to help you where to focus. And so what do you think is the problem? As you can see clearly that this non-contrast CT is showing the lumen. Is my arrow visible, Vijat?
The arrow, your
The
pointer,
pointer,
yes.
sorry, not the arrow, pointer.
Yeah, yeah. It's
Yes.
visible. It's black, but you can see it.
Okay. So this is showing the lumen of the ureter, and you can see that it is hypodense. Whereas if you look at this cut, there is a dilated ureter, and it is showing contrast enhancement. So cystoscopy was planned, and we did cystoscopy plus ureteroscopy. The ureteric orifice was tight. There was a small unifocal tumor. Complete removal of the tumor was done. And the base of, not case, but base of the tumor was ablated with laser. Intravesical mitomycin C is given in the recovery room. Although there was nothing in the bladder, but we know that we have manipulated the tumor in the ureter. We have potential seeding possibility of upper tract urothelial cancer into the bladder, and particularly, and at this point, we don't know whether it's a low grade or a high grade disease. So it is safer to put mitomycin or gemcitabine, whichever you preferably use, into the bladder, and that is not going to harm. It is maybe of some use. So same case, follow up after, and after, sorry, the rest of the his story is that his came out to be unifocal, low volume, low size, low grade cancer. So it was categorized as low risk disease, and options of treatment, including active surveillance, was offered to the patient, and he opted for active surveillance. However, he was lost to follow up, and he came back about 1.5 years later, And during cystoscopy, we noted that there is a tumor at the bladder neck, which was completely removed by an arm block TURBT. And there was tumor in the lower pole of the same site, which was laser ablated, biopsied and laser ablated. Okay. So the question is, what next? Is he a candidate? Let me see if there is an MCQ. Yeah. So now this patient has the biopsy is still low grade. He's got a recurrent urothelial cancer, and it is at a different point where it was previously. So, would you consider doing? We are dealing with a multifocal disease. Should we recommend nephroureterectomy for upper tract and intravesical mitomycin for the bladder cancer? We should do resection plus JJ stent plus intracavitary mitomycin. We give intravesical chemotherapy plus upper tract intracavitary installations, resect and rescope. So, what would you guys prefer? Okay, so A and C are the two options coming up. Nephroureterectomy for upper tract and intravesical chemo. Some of you also opted for B, which is resection. Fine. Okay, so already we are seeing that there is significant conflict on how this patient is managed. Right. So if you go for A, and maybe all of you are right, or maybe all of you can give this option to your patient and let him or her decide what is the best. So nephroureterectomy, again, it's oncologically, it is going to give a wonderful outcome because you have removed the renal unit and the ureter and cuff of bladder, and the chances of recurrence of disease is going to be extremely low. Now, if you go for B, resection plus JJ stent plus intracavitary mitomycin C or intravesical chemotherapy, this will help in reflux of the chemotherapy from the bladder um, into the upper tract, and that may be of help. Again, it's a way of conserving the renal unit. If you give intravesical chemotherapy for bladder tumor and intracavitary installations by either a ureteric catheter or by percutaneous approach, that's another option. Resect and rescope is another option. So if you give these options, the likelihood opt for resection and rescope, hoping that the tumor, but I think D is going to be the least favored option because we know that this is a recurrent disease and it may recur more if we don't do anything. Okay. So this patient decided not to have anything else. And we did the next cystoscopy, and what we noted is there are multiple recurrences in the calyx and infundibulum. And you can see that this is one of the calyx where there is crops of tumor. Still looks like low-grade disease. All these tumors were laser ablated, and the prior biopsy was also done. The biopsy showed that it's a low-grade disease, still TA, non-invasive. It is not going beyond into the lamina propria. And intravesical MMC was given. There was also, now he has developed a ureteral stricture. So one of the questions that I earlier asked about the use of contralateral ureteroscopy is that, remember, ureteroscopy is not a benign procedure. It has a risk of developing urethral strictures, and recurrent ureteroscopy have a significant potential. So it's important that you do it very carefully. And this patient developed urethral stricture, which was dilated and stented. What would be the next management step in this case? Now that he refused nephroureterectomy and his next cystoscopy has showed multiple recurrences, both in the upper tract and in the bladder. So what would you do next? Should you consider systemic chemotherapy as a neoadjuvant chemotherapy followed by radical nephroureterectomy? You should consider intravesical chemo with stent, percutaneous intracavitary chemotherapy, or active surveillance. Okay, Ramna is hell bent on removing his kidney and ureter, and the patient is hell bent on trying to preserve his kidney and ureter. So Nazish and Adnan and Israr, they're all going for percutaneous intracavitary therapy. Okay, so there are more converts now. Good. So that's a very good option if you want to preserve the renal unit. So a nephrostomy tube was placed, and deliberately it was placed in the upper pole calyx. The whole idea of upper pole calyx, although the disease was more in the lower pole and the middle pole calyx, but it was placed deliberately there. First of all, there is no direct disease in that calyx. Secondly, there is a greater chance when you instill chemotherapy that it would get in contact with all the calyces. And this time, gemcitabine induction intracavitary chemotherapy was done. The dose is typically 1 gram in 50 ml of saline, which is attached to a drip, and it is on gravity over 1 hour weekly for 6 weeks. Very similar to what we do for intravesical. So typically, the nephrostomy tubes is replaced every 2 to 3 cycles, and we completed 6 weeks of intravesical intracavitary chemotherapy. While he was on induction, followed by maintenance intravesical chemotherapy, we did ureteroscopy, and prior to that, you can see a retrograde was performed, and there is a stricture which we previously dilated as well. Cystoscopy at that time showed there were multiple papillary tumors in the bladder. We did the contrast CT, CT urography, which shows multiple filling defects in the ureter. What are the options of management now? Okay. Wonderful. So all of you are now saying that radical nephroureterectomy and intravesical BCG for the bladder is what should be done, because we have seen that most of our conservative or renal sparing treatment options have failed. And you are absolutely right. However, ziddi mareez ka kya kiya jaye? He wishes to preserve his kidney. His lower urinary tract symptoms are worsened. His creatinine is going up. He received intravesical BCG. CT showed worsening disease of the upper tract. And finally, he agreed to undergo radical nephroureterectomy His follow-up now is about just over 2 years, and so far he is doing well. Okay, so this was a case, and you can see that we started off with a low-risk disease. However, the follow-up, and you can also understand that the follow-up has to be extremely stringent, and those patients who you think that they are not going to follow very religiously, then you should offer a nephrectomy, because as you can see, even a low-grade isolated tumor, that's how we started off, progressed into multifocal disease, both in the upper tract as well as in the bladder. In the bladder, there was no disease. So it's important that those who are not going to follow should not undergo conservative treatment, and they should be offered even for low-risk cancer. Something that is difficult to sell, that's one option. Okay. Now look at some other issues related to high-grade and locally advanced upper tract urothelial cancer. So patients, majority of these patients presents with locally advanced disease, and because most of the upper tract cancers are very aggressive, and it is often discovered incidentally. If not, they present at a higher stage. The standard of care for these patients is radical nephrectomy with bladder cuff excision. However, if you look at the outcome of radical nephrectomy at 5 years, we see that the recurrence-free survival could be as low as 50%. The intravesical recurrences are seen in 1/4 to 1/2 of the patient. The cancer-specific survival for localized disease is good, but still it can be up to 50%, but in some of the cases it could be even 90%. Cancer-specific survival for node-positive disease is low. It's only 35%. So at 5 years, you can have a significant increase in metastatic disease, particularly if you have nodal disease. How can you reduce that? And we know that we have learned from the bladder cancer that use of systemic chemotherapy can have a significant benefit effect for high-risk cancer. So the solution is systemic chemotherapy. We know that the radical nephrectomy, if properly performed, involves en bloc removal of the kidney, ureter, and bladder cuff. It's important that you avoid entering into the urinary tract, and you work all outside the urinary tract except when we are doing a bladder cuff, and that too after you applied the clips on the distal ureter, distal to the tumor, and only at that point you enter into the bladder, because there's a significant chance of tumor seedling. Bladder cuff, there are various techniques of doing bladder cuffs, and we are going to talk about this, I think, on the third Saturday of this month, and when we talk about upper tract surgery, and we're going to go into the details of all this, but just suffice to say there are various ways of doing bladder cuff excision. Nodal dissection for low risk cancers, low stage cancers like Ta/T1 is unnecessary. Nodal dissection carries some risk, and it should be done for high risk patients where there is poor preoperative staging, because CT may not have picked up disease. It has low morbidity, and it should be template based upon, and these discussion will come later. What is template based is depending upon where your primary tumor is. From that point of view, you can remove lymph nodes accordingly. So whether it's upper renal pelvis and proximal ureter, middle ureter, distal ureter, accordingly you will do the nodal dissection. Now, what are the challenges of systemic chemotherapy? One of the challenge is that you know that cisplatin, which is the mainstay of treatment in urothelial cancer, cannot be given on patients who have poor renal function. So, and we see that about 40% of patients have a decline in their GFR post chemotherapy, so they become poor candidate for surgery. If you do it preoperatively in a neoadjuvant setup, after nephroureterectomy, if you do as adjuvant treatment, then again there is a problem that a lot of these patients lose a significant portion of their kidney function. So one of the problem that we face is incorrect diagnosis and staging of the upper tract urothelial cancer. So what may be come out from your biopsy is probably not very representative. And at times when you've taken one or two biopsies, the field becomes bloody and it becomes difficult to really see if there is any higher grade or more sessile growth in the ureter or upper tract, which you are missing out. CT scan uh, cannot differentiate from non-muscle invasive to T2 disease. However, if it is T3 or T4 disease, your imaging is very helpful. So let's move on to another case, and this is case number 2 with a 58-year-old male, again a smoker, gross painless intermittent hematuria, controlled hypertensive. His creatinine and hemoglobin were okay. Urinalysis show that there is greater than 20 RBCs per high power field. And as you can see in the CT scans, are we going to ask you? Yeah. So look at the CT scans. I'm not going to tell you what is there. So these are various phases of the CT. And we'll just have a quick look at all the films, and then I'll ask you a question about what do you think the CT is showing. Okay, if you have seen it, let's move on to the question. It's a unilateral upper tract tumor plus lymph node, unilateral obstructive uropathy, right renal pelvic tumor, right collecting system tumor in the calyces. Collecting system means calyces. Okay, perfect. Very good. So yes, those who have answered so far have answered it correctly, that there is a unilateral left-sided upper tract tumor plus nodal disease. And you can see the node here, quite a big node. Cystoscopy was done, and you can see that it was not a very easy procedure, and we were with difficulty able to biopsy one tumor, and then it became so bloody that it was not possible to continue. Plus, he had an obstruction. So after taking a few biopsies, we put a double J stent, and we also had a suspicious area in the bladder, as you can see here, that was also biopsied. The biopsy is difficult in ureteroscopy. You have very limited space, and the gadgets have to be appropriate. So it's important that you have the appropriate cold cup biopsy for your flexible ureteroscopy available to do this biopsy. Otherwise, you have to use a zero tip basket to grab the tumor and pull, which is not preferable. But if you don't have these forceps for flexible ureteroscope, or if it is in the ureter, you can use semi-rigid or rigid ureteroscope to do the biopsy, which is relatively easier and the equipment is more easily available. So this is using the zero tip basket to grab a tumor and then pluck it. And sometimes you're very lucky and you can get a real good specimen. So one important thing is that when you're taking a biopsy in the in the uh, ureter, but also in the renal pelvis, is that typically you take a biopsy and you pull, whereas in upper tract, it is advisable to hold the tumor from the base and push it, because what you can see is the cavity in front and not uh, behind the scope. So when you pull it, you may lose vision. So it's better to hold the tumor from the base and push forceps towards the lumen to retrieve the specimen. So what we got on the pathology is a low-grade papillary urothelial cancer of the ureter. Although clinically it is at least T3 and also node positive. Cytology was showing Paris 3, and you know that this is the Paris classification of reporting cytology. So if you have 3 and 4 and 5, then it is a bad omen, which means that you're dealing with a high risk disease, high grade cancer. Whereas if you have 1 and 2 or 6 and 7, then it is either non-diagnostic or you're dealing with a low-grade disease. And I will skip some of the cytology details here. Now, this situation, we were now facing that the CT scan is showing a T3 at least node positive disease, whereas the biopsy is showing a low-grade cancer. So obviously, you cannot take the decision on either one of these modalities, because one is saying low grade, one low risk, and the other one is saying high risk. So how would you make a decision? So we opted for doing a biopsy, a CT guided biopsy of the lymph node was performed. And this specimen showed CK7, GATA3, and P63 positive, and all these are indicative of urothelial cancer. And it was a metastatic poorly differentiated carcinoma with immunohistochemistry showing an invasive urothelial cancer. So now we have evidence that this patient has a urothelial cancer metastatic to the lymph nodes with the T3 at least on CT scan. And how will you manage this patient? Now you know more about him than when we took the biopsy. By the way, the cytology was also positive. So, okay. So barring one or two people, most are in favor of A, then some Bs and Ds as well. Okay. So it's a node positive cancer with the undersampling of the primary. So go for nephroureterectomy plus nodal dissection. Well, that's one option. Chemotherapy followed by nephroureterectomy plus nodal dissection. Percutaneous biopsy that we have already done, sorry. And, percutaneous biopsy for the primary tumor. So maybe we have missed out. The patient may say that, well, on histopathology, it's a low risk disease. Why are you removing my kidney? So can you do a percutaneous biopsy of the primary tumor? Because there you can take a much more representative specimen, or do a PET scan and see exactly if what we are dealing with in the upper tract is really T3 disease and not just obstruction secondary to something else. Remember, according to the European Union classification, the EAU guidelines, patients with hydronephrosis is a risk factor for having a high-risk cancer. So majority of parameters are indicating that he has a high-risk cancer, so for which either a neoadjuvant chemo followed by nephroureterectomy or nephroureterectomy, nodal dissection, and then followed by adjuvant chemotherapy are two options. So in my opinion, this patient is more appropriate for neoadjuvant chemotherapy. And the reason is that neoadjuvant chemotherapy will probably take care of his micrometastatic disease, because if node is positive, you remember that I showed you earlier on that if the node is positive, then 5-year survival is less than 70%, less than 40%. So it's about 35%. So if you don't do any chemo now, you may miss the time to take care of metastatic disease. You do a radical nephroureterectomy, and then 6-8 weeks later, you do another CT scan before systemic chemo, and you find that disease is much more advanced than what it was. So in my opinion, better option is to go for neoadjuvant chemo, followed by radical nephroureterectomy. And that's what we are doing with this patient. So he's already receiving his neoadjuvant chemo, and soon we will discuss option of nodal dissection and nephrectomy. Okay, so I think we have already discussed this part. Okay. Now, a few words about perioperative chemotherapy in neoadjuvant setting and adjuvant setting. So the advantage of doing it in the neoadjuvant setting is that you have maximal renal function, which means that obviously the likelihood that GFR is normal is there. There would be significant pathological downstaging when you're doing the surgery. Complete response rate can be found in patients who undergo neoadjuvant chemo followed by radical nephroureterectomy. It's possible that you may find on your specimen RYP2 not disease, which essentially means that neoadjuvant chemotherapy has taken care of at least visible disease. And the chances of 5-year survival in these patients is much better than those who have a persistent T2 disease after chemotherapy. So it's very similar to what we have discussed in the bladder cancer. And you can have YPT1, which is post-neoadjuvant pathology of radical nephroureterectomy specimen, showing that there is only a T1 cancer and no invasive disease. So it is found in up to 60% of cases. So we have high quality data now available about use of neoadjuvant chemotherapy, and this is all indicating that there is a significant improvement. But as we have discussed in bladder cancer, the most important question is the eligibility of these patients to undergo neoadjuvant chemotherapy, which means that they should be cisplatin eligible. And we have talked about functional class, talked about kidney functions, audiometric evaluation, presence of peripheral neuropathies, and cardiac insufficiencies as defined by the European Association guidelines. So if you look at these guidelines, you need to assess your patient to see if any of these contraindications are there, whether this patient is eligible for cisplatin or this patient is eligible for carboplatin, which means that the GFR is between 30 and 60. However, if the GFR is less than 30, then this patient is not eligible for any type of platinum-based chemotherapy. So what about those who are not eligible for neoadjuvant chemotherapy or even adjuvant chemotherapy, is there a role of immunotherapy? And now we know that we are living in the era of immunotherapy. However, overall, there is although some data for bladder cancer, but still nothing substantive at the moment on immunotherapy in the neoadjuvant setup in upper tract urothelial cancer. Okay. So neoadjuvant was not given. Patient underwent radical nephroureterectomy. This is a POUT trial. Alison Bertel reported in Lancet in 2020. And it showed that it's a phase 3 randomized controlled trial. 4 cycles of adjuvant gemcitabine platinum combination therapy was given because some majority had cisplatin, but some had carboplatin as well. And the nephroureterectomy was done within 3 months versus active surveillance. And it showed that patients who had adjuvant chemotherapy were much more, they have shown a significantly improved 3-year disease-free survival, 5-year as well. And now we have a longer data available for. So if you look at the updated outcomes, the 5-year disease-free survival is 62% versus 45% for those who were on active surveillance after radical nephroureterectomy versus those who received chemotherapy after surgery. The overall survival is 1.5 years more in patients who receive chemo versus those who were on. And the 5-year overall survival was 66% versus 57% in the 2 arms. So, I mean, it is showing that there is significant advantage of platinum-based chemotherapy with gemcitabine in adjuvant setting as well. One of the limitation of post-operative chemotherapy is the GFR. And we know that after unilateral nephroureterectomy, a significant proportion of patients can lose their kidney function to be eligible for chemotherapy. About adjuvant immuno-oncological agents for those who are not eligible. Again, if you look at the quality of data, the recommendations are weak for use of PD-L1 inhibitors, nivolumab in adjuvant setting. So we still need some better quality data to indicate use of adjuvant immunotherapy in patients who are not eligible. So those who have poor kidney functions after radical nephroureterectomy are really at risk of developing metastatic disease. These are some of the guidelines from the leading associations, the American Association and the EAU guidelines and the National Cancer Network version 6 guidelines of 2025. And essentially, they are saying more or less the same thing, what we have discussed in detail in the last 50 minutes, talking about the use of intracavitary chemotherapy for small risk, low risk cancers, use of nephroureterectomy, how it should be done, how much should be removed, and the particularly important is surveillance after nephroureterectomy, particularly for bladder recurrence and also the contralateral site. So I'll stop here, and if there are any questions or any comments.
So probably much of the trickier part was covered by the questions and answers, but many of the people would love to know the right answers.
Okay. So The whole idea of not giving you the right answers was that there is lack of clarity on issues. So there is more than one correct answer for most of the questions asked. So let me go back to the questions and
Probably keeping the chemotherapy for upper tract TCC inside the renal pelvis or the upper tract. I mean, people have tried different things, but there is no clear-cut answer for it, probably.
yeah. So the advantage of percutaneous approach is that it can preserve kidney function. The chances of tract seedling, which was a concern that we have initially for kidney cancers and then obviously for upper tract cancer as well, has not been shown. It's more of anecdotal. So it is safe to do percutaneous approach. And percutaneous approach gives you options of renal preservation for bladder, bigger tumors, because it's not possible to remove significant portion of bigger tumors uh, by a retrograde approach. So in response to this first question, low-grade tumor, which modality would you consider for intracavitary chemotherapy? So for low-grade cancer, which is low risk or intermediate risk is not a defined entity, but if you are still low grade with maybe one or two tumors, or tumor which is slightly more than 2 centimeters, one should consider intravesical chemotherapy with double J stent. Only intravesical chemotherapy does not suffice. And for low volume cancer, intracavitary chemotherapy via PCN is, I think, an overkill. So by and large, percutaneous approach, the retrograde approach using double J stent is a fair option in this situation. The problem with the intracavitary chemotherapy using an open-ended catheter, putting every week, doing a procedure of flexible cystoscopy, putting a catheter, doing thing, is a bit cumbersome exercise, but it's a doable thing. And if your system allows doing this, that's another thing that can be done. So that's also quite safe. About this question that low-grade upper tract, when will you do ureteroscopy? As I've said, that ureteroscopy of the contralateral side is not a totally benign procedure, and one should be very careful because if there is an evidence on or disease progression or cytology positive from the contralateral side, definitely you need to do it. If there is radiological progression, you also need to do it.
Very interesting question that if you give chemotherapy for an upper tract TCC, would it cover the lower tract as well?
The disease, the drug concentration by the time it reaches the bladder is not optimum for treatment of bladder cancer. So, in my opinion, no, it doesn't. Okay, so combined, yes. Saraf, it is better to do. If you have, say, intermediate risk tumor in the bladder and you have low risk cancer in the upper tract, then you do combined chemotherapy. Any more comment? In case of patient required adjuvant chemotherapy had recurrence. Okay, so yeah. Is URS biopsy needed in all upper tract TCC? I think, Nematullah, if what you mean is that if there are multiple tumors, should you remove every tumor? If it is possible, it's a preferable thing. So our speculation, there is no strong scientific evidence, but we are doing for upper tract cancer, mostly what we do for our bladder cancer. So consider your urothelial cancer in the bladder, you have multiple tumors. We should remove all. So no asking for single one. If we give chemo,
And probably Nemat's question is that if a patient have a radiological evidence of upper tract, can you go straight forward and go for a nephrouretrectomy or do a URS first mandatory?
okay, so this is a question that I think it was addressed in Islamabad PAUS meeting 2024. And in NHS, CT evidence of T3 disease, you are not doing ureteroscopy, you are doing direct nephrouretrectomy. So this is what was told to us by some of the surgeons visiting from UK. I personally think that this is more due to the problems in NHS in giving in appropriate time to patients having two procedures rather than an actual scientific thing. And Mazhar Sheikh has raised, oh, we have a visitor from UK. Yes, Mazhar, please proceed. Can somebody open Dr. Mazhar's mic if that's an issue? Is there a problem with opening the mic, Mazhar? Sharif, can you open if you're around? Can you open?
Yes, sir.
Okay. Mazhar
Okay,
bhai, please.
Good afternoon, everyone, and sorry for joining late again. I was at work. So, Prof, excellent presentation. What I have caught up, but I'm not surprised. Prof, as this is an issue that we all face globally, as you have alluded in UK, the factor that affect the delay is one of the factors that people are suggesting. Why don't we do a direct nephrouretrectomy? However, Prof, there was an audit done under BAUS, Bhavan Rai, another few colleagues have done it. Still, the standard practice is still doing a ureteroscopy. It hasn't changed, but there is a significant trend doing either on-table ureteroscopy and proceed directly if you are not clear. Otherwise, still we are doing ureteroscopy. So the standard of care has not changed, but many of the centers are doing direct nephrouretrectomy if needing doing the ureteroscopy, and at the time of consultation, radiological evidence and cytology. Because in the past we were not using cytology as much, but
Yeah.
now cytology, other markers are in place with the use of CT evidence.
Yeah, I mean, I think it has its practical value. But again, the paradigm of performing a major oncological procedure like nephrouretrectomy without histological evidence of disease, and we know cytology, although it's very sensitive, but the specificity of cytology is low. So, in once in a while, you will have a case which was not upper tract cancer, which was something else, and you may
Yeah.
regret what you've done.
Absolutely,
But
Prof. In our unit, we're still doing ureteroscopy. So still, what we try to catch up that we will not have a patient waiting for 3 months. We do the ureteroscopy within 4 weeks. The patient will be in theater. So that's the way we are working on.
Okay, great. Thank you very much, Mazhar, for providing that perspective. And I don't see, Vijat, if there are any further questions or comments.
I think it was comprehensively covered, and most of the questions and queries were responded, and we are well in time. So, thank you, sir. Thank you,
Thank you
everybody, for
very
participating.
much. We'll see you next Saturday for our operative urology of the bladder cancer. So 4 weeks of operative urology covering all aspects of bladder cancer management. Thank you and have a very good evening and a very good weekend.
That concludes our session for today. Thank you.